Today's topic is cardiac conduction system. What we'll be doing is, say as such, we know about SA node, AV node, right? Bundle of phase, etc. This would be like summarization of everything whatsoever we have learned in this part of time about the conduction system, right? About the conduction system. So this will be the foundation as we'll be proceeding from next time for what is called as the cardiac arrhythmias, right? Cardiac arrhythmia. That means what really happens when SA node goes wrong, what really happens when AV node will go wrong, what would happen when there is some bundle branch block, all the types, type 1, type 2, type 3. So all those things is what we'll be discussing from the next time onwards. Sorry. So this would be, today's session will be like foundation for those who have not attended the previous lectures. Right? And if you know about certain things, so you'll definitely be getting, it will be adding some value added information for today because it will be in combination with the clinics, right? So I think, all right, it's time, let's start. So we'll talk about the cardiac conduction system. Now in this, we'll take it in a slightly different way from the clinical aspect. Right? That is when you'll be studying USMLE part 2. So even at that point, these things will come. Okay. So when we say cardiac conduction system, we'll learn it into 3 parts. First part would be very easy. It is about which you already know, from SA node all the way up to the Purkinje fibers. Right? Purkinje fibers. We'll just have a very quick overview so that everyone please let's know about all ebooks. Sure, we'll talk about this, all the ebooks at the end. Right? Definitely we'll talk about it. So SA node to all the way up to the Purkinje fibers, what really happens to those fibers and what is the importance? We'll see that. The next section will be the pacemaker. There are few pacemaker tissues, and some are non-pacemaker tissues. Non-pacemaker tissues. When they say pharmacology of cardiology is very tough, no, it's not tough because it is this and this understanding of pacemaker and non-pacemaker. Once you know this difference, everything becomes very easy, and that's why we have added the fourth component, and that is there are some variables. Variables means over here we'll be talking about some part of medicine, some part of receptor, some part of pharmacology. We'll be talking about one specific syndrome like say Brugada syndrome. So not to worry about the name, but what really happens in that case. So if you have understood this part and this part well, you'll be able to understand literally the Brugada syndrome in 1 minute. Right? So this would be like a trailer that what you can really expect as you'll be proceeding higher into your medical studies, right? Because when you'll be discussing pharmacology, no one would come and say that, okay, this is phase 0 is affected or phase 1 is affected. No, straight away they'll keep on telling you about these channels are closed, these channels are open. But this would be the foundation. Right? So that's why today's session is important from this perspective. Let's start with our first part. So here is our conduction system, right? And putting it into simple words, this is the SA node, right? Which is our primary pacemaker. From SA node to it goes to the AV node, right? In between AV node, right? Some of the fibers they will be going to the right atrium. Left atrium is a bit far. Correct. So there will be a specific bundle which will be going, and that is called as the Bachmann's bundle, right? Bachmann's bundle. So that will be supplying solely to the left atrium. From AV node, there goes one bundle, right? It is called as the bundle of His. This bundle, it gets divided into 2 parts, right? The right side and the left side. So that's why there would be one entity which will be called as a right bundle branch block, right? When we'll be learning arrhythmias. That is what really happens when the heart is not moving into its rhythm. So it is called as the right bundle branch block. So it means we are simply talking about this is the problem. That means where the problem will occur? Problem will occur into the right bundle branch. Right bundle branch which will be supplying what? Right bundle branch will be supplying to right ventricle, not the right atrium, because right atrium has been supplied directly by the SA node or the sinoatrial node. It is called as the sinoatrial node. So these nodes are what? These nodes are self-motivated. They keep on sending the pulse, right? Similarly, this is AV node, right? That is called as the atrioventricular node because it is at the junction of atria and the ventricle, right? So if we really draw the heart like a classical figure, right? So this is the area, that is where it is the SA node. AV node is at a junction of atria and ventricle, right? And this is the Buckman's bundle, and this is the branch which will be supplying to the right atrium. This is right atrium, this is the left atrium, this is the right ventricle, and this is the left ventricle. And from here, this bundle of his would start, and there would be one branch which will be going to right ventricle, and there would be one branch which will be going towards the left ventricle. But all we need to understand is that left side, left bundle branch has got two parts, right? Remember, it has got two parts. One, what is called as the anterior bundle, and second is called as the posterior bundle, right? Anterior bundle means these are nothing but nerves, right? So these are the nerves. So this is the anterior bundle and the posterior bundle. Then after that, they will divide into multiple branches, right? Multiple branches, and we'll collectively be calling all of them as Purkinje fibers. Right? Purkinje fibers. These are the fibers, in fact, which will be going into the musculature and they'll be supplying deep to it. Okay, so this is the circuit. Now, that's our SA node, right? That's our SA node. This is what is called as the primary pacemaker. Pacemaker means what? Pacemaker, when say in the race, right? Whenever you run any of the marathon, so there are some pacers. Those pacers, they are given only one. That let's say if you are a pacer of 4 hours, right? 4 hours. So you complete full marathon in 4 hours. So you'll be having one flag on your back, and on which it would be written like 4-hour bus, right? And this guy will keep on running at a speed of more than 10 kilometers per hour so that he finishes the race by 4 hours, right? So he's a pacer. He is not motivated by anything. His function is only to finish the race within that much time. Now, if you want to run at that pace, you join this person. That's why this is called as bus, right? So if he reaches in 4 hours, you'll also reach. So thus there will be 4-hour bus, 4.5-hour bus, 5-hour bus, 5.5-hour bus. So depending upon your capacity, you join the bus so that pacer will be acting as a motivation. But pacer has got no motivation, right? He is self-motivated exactly the same way as a node. They are self-motivated. When we say self-motivated, that means they won't need any impulse to trigger. There is no impulse, right? Impulse is not needed. There is nothing is needed. They generate the impulse by themselves. So that's why they are the primary pacemaker. That means they are the site of automatic electric impulse generator. So this is what it is. Now it generates, what is the pace? Pace means speed. At what speed it will keep on sending the signals? And it is 60 to 100. 60 to 100. What if it is more? Well, he only will do, but under normal circumstances, if you really check your heart rate, it will be falling between 60 to 100, right? 60 to 100 per minute. This is primary. The important thing is, this is supplied by the right coronary artery. Now, why we are mixing the arteries with it? What we are trying to understand is that whenever because see, when you'll be examining the patient and when you'll be treating the patient, it is not so you'll say, I'll treat only the conduction system. No, it is the entire heart which is to be taken in consideration together. Right? So that's why any of the blockage of any of the artery, you should know that where it will affect. So this is the right coronary artery, right? It is supplied by it supplies SA node. On to the AV node. AV node is atrioventricular node. The specialty of AV node, as if you have attended previous lectures, in second you will say that multiple times we used to say that AV node is the only window between upper heart and the lower heart. Right? I repeat, this is upper heart, right? Atria. This is lower heart, ventricle, right, left, that's it. But basically, this heart is divided into two parts, upper heart and lower heart. So here, this AV node is the only window via which the current can really go from up to down. That means it cannot go from here, it cannot go from here. While in case of atria, yes, Buckman's bundle is there, here are some fibers, they cross all, right? Once things come down, then there are fibers here, there's few fibers here, all those things, that mixing will occur. But in AV node is the only window, right? Only window between upper heart and lower heart. Is it important? Well, when some things which are normally occurring, right, we don't feel the importance. But when in some of the pathological state, when the signals, there are some random signals which will be generated and which can go like this. They'll go from top to bottom, not via AV node. So due to that, there would be total desynchronization between upper heart and lower heart, and it can lead to so many complications, right? Which is what we'll be understanding when we'll be learning arrhythmia. So we'll be learning arrhythmias from two perspectives. One, where the current is going wrong, and second, because of that current, some chambers will be contracting early, some chambers will be contracting aram se, right? Or some chamber is contracting normally, and then suddenly once again one signal comes contract, right? Bichari, it is contracting, and second signal comes, it contracts. Or when it is relaxing, signal comes contract. So now you can know. When it is relaxing, that means when it is distally, when it is dilating, when it is filling, at that time signal comes to contract. So whatever that less amount of blood is there, it will be thrown, right? Thus, it will be generating an abnormal pattern onto the ECG. This is the reason we shall be combining hemodynamics with the electrical system, because in reality, both of them will be running together. But AV node, that is the only window. That means if normally the current has to go from top to bottom, it has to via AV node only. So this is one, right? Only. This is first point, most important point. Second important point when we talk about AV node, and that is it delays conduction. It slows down. Why it has to slow down? Once again, the hemodynamics comes into picture. Delays conduction from SA node. It slows down because atria has contracted signals, electrical signals, they move much faster. So when they move from upper heart to lower heart, immediately they say lower heart contract, that is ventricle contract. Ventricles could give the time to them so that they fill up with the blood, right? They need some time. So that's why this signal is delayed over here, to slow down. Right? SA node tells send the signal further. AV node will say yes, sending. Every time it will put some delay. That's the reason this is the P wave, right? P wave. And then that P wave is generated by atrial depolarization. So because of right and left atria, this P wave is generated. Now it has reached to AV node. AV node is sitting silently, not sending anything. So that's why this is a flat line, isolated line, flat line. and then it sends the signal and we get QRS complex. QRS complex. So this delay, right, this delay that is generated because EV slows down. In case if there is no override suppression means SA is the boss. SA says we need to beat at 80 beats per minute. This bichara will say my speed is right. Here, the pacer rate of AV node is much less, right? It is 45 to 55. But pacer means AV node will be having the burning desire in its heart that one day I will also be. His AV node is not knowing that it will be very bad. But every time enthusiastically, AV node will say, my signal is ready, I'm sending. And then the signal from SA node comes and tells, Chal chup, shant, send this signal. He'll say, okay, no problem, next time, right? And once again, it will start processing, right? And again, the signal from the top comes. And so this is what is called as the pacer rate, but it is not dominant, it is dominated by SA node. So that is what is called as the override suppression. This is suppressed because of the overriding of signal, because of the more powerful, more frequent signal from the SA node. This is supplied by, now AV node comes down, right? So this is supplied by PD. Now this PDA, this is what is called as the posterior descending coronary artery, correct? Posterior descending artery. Now this posterior descending artery, which goes at the base, gives one fiber to this AV node. Right? So PDA is usually from RCA. Right? I'll just make this thing bit simple. Right? This is the aorta. From aorta comes the right coronary artery from right side, and from the left side there comes the left main coronary artery. Correct? That right coronary artery, that will be giving one branch sideways. So that is called as the left circumflex. Another one which goes straight away down, that is called as the left anterior descending, right? LAD. This LAD is most vital because it is also called as the widowmaker. The reason, it is supplying the left ventricle and at the same time the septum, interventricular septum, which is crucial. But at this point of time, we are not discussing it. This is what we are discussing is there is one branch. There is one branch which is called as the PDA, posterior descending artery, right? Posterior descending artery. This particular artery, usually it emerges from right coronary artery, and that is what is called as the right dominance. Right dominance. Right. So when this is coming from left, it is called as the left dominance. When sometimes in very rare cases it comes from both, right, partially. So that is called as the co-dominance. But in 85% of the cases, that is in most of the cases, you find that it is coming from right coronary artery. So this is the important part, that this PDA, posterior descending artery, is actually supplying AV node. Very important, correct? So that is what really happens to it. On to the bundle of His, right? Bundle of His. So it is that which is coming out from the AV node, and it is this common bundle. So bundle of His, if it is asked that what is the importance of bundle of His, and there will be several answers, but this one thing, it prevents, see, wonderful mechanism, it prevents, in capital, retrograde. Retrograde means the signal should not go back. So this prevents retrograde electrical conduction, right? Retrograde electrical conduction. Signal won't go back, right? That is the importance of it. So here, as we said, that there would be the right bundle and there would be the left bundle, correct? So this right bundle will supply right ventricle, Right? What's the big deal in that? And left bundle, that will supply left ventricle. Correct? Left ventricle. No doubt there will be anterior, posterior part and this, that, everything, but basically this is how things are distributed. And finally, there would be like Purkinje fibers. So from here, the Purkinje fibers, they are coming out. And these are the Purkinje fibers which will be supplying to all the ventricular musculature. Right? It is called as the ventricular musculature. Now, in any of the competitive exams, they ask you some tricky questions where they know that mostly people will be committing error into it. One of the such killer question is when you are asked for the conduction velocity. In Viva, etc., such questions rarely come, very rarely, and no one asks. But its importance, conduction velocity. See, from SA node, signal started, reached to AV node. We know that AV node will be slowing down the things, right? But then signals will move on to bundle of hairs. Then signals will be going into the Purkinje fibers. The speed at which it will be traveling into these various types of fiber is called as the conduction velocity. Velocity means speed in specific direction, right? We learned it in 10th. Right? When we say speedometer is telling our speed is 80 kilometers per hour. Fine, that is called as speed. But when we say velocity, then it is said 80 kilometers per hour in which direction? That is what is called as the conduction velocity. That is called as the velocity. So over here, direction is important. So here, the point is, question which is asked is that in heart, which tissue is having the highest conduction velocity? And very happily we say SA node, right? And we go totally wrong. SA node is a pacer, right? Every 100, in 1 minute, 100 times we say go, go, go. But then the signals, they are going at their own pace. But SA node is like telling yes, go. What happens? Conduction velocity, it is fastest in Purkinje fibers. Right? Purkinje fibers. Now Purkinje fibers, if SA node fails, AV node fails, bundle of his fails, so then Purkinje fiber, they will start generating the signal. But that would be their pacing rate. There is a difference between conduction velocity and the pacing rate. Pacing rate is at what pace at what speed he opens his eyes and gets, oh, go, signal, go. Right? It means this is like a bus stop. This is like a bus stop. After what duration? Right? This is like a bus depot. Right? Let's keep it a bus depot. It has got several buses. At what interval it is telling, okay, new bus, go. New bus, go. That is what is called as the pacing. So if it is Purkinje fibers, so every 20 seconds, if 20 times, so every 3 seconds, it gives me 20 times per minute. So every 3 seconds, it will say go, right? But when this bus will come out of the depot, it will go fastest. That's the difference, right? So Purkinje fibers, once the current enters into Purkinje fibers, it goes rapidly. So it is more than next type of tissue. That is not ventricle, that is atria. It is what is called as the atrial myocytes. Atrial myocytes, they are fast, right? Because small, directly supplied, and then they need to react instantly. Because see, Buckman's bundle is a bit long. So this and this, they both should contract. So that's why there is minimal delay, so they contract immediately. Then atrial myocytes, the next number comes is a ventricular myocyte. Ventricular myocytes. And last one, the slowest is AV node. SNO, slowest. So if the signal is to be generated, right, they will take time. They are the slowest, but they generate signal faster. So actually, when the signal comes into them, right, the AV node is known. So that's why we'll just keep AV node as the slowest, because AV node deliberately slows it down. Right? So now, I hope you now know the difference between conduction velocity and the pacing rate. Correct? Still, if there is any doubt. Okay. So now, the next is, we'll be talking about pacemaker action potential. Pacemaker action potential. To make things easy, we'll just see the graph, right? Straight away we'll see the graph and we'll come to it. So here is the graph, and this is the membrane potential, right, which is into millivolts, against the time, right? And we plot one graph and let's see what really happens. The whole game, right, it is at -60. The whole game starts at this level. There is something what is called as the funny channel or the funny current. So here is the cell, and when we talk about pacemaker action potential, that means we are dealing with either SA node or AV node. The rest of the tissues of the heart will be considered as non-pacemaker. Right? So as a pacemaker, SA node and AV node. So here starts the journey. This is a cell, right? This is a cell. Which cell? It is from SA node or AV node. So in case of SA node or even AV node, this particular cell, we know that there is sodium outside and potassium inside. Sodium is outside and the potassium is inside. It is the first thing they exit. This is what is called as the automaticity. Automaticity means it is a technical word for spontaneous depolarization. That means it is automatically sending the signal. Right? Automatically sending the signal. So no stimulus is needed. Keep on doing. Yes, you can control it, right? Your brain can control sympathetic, parasympathetic. We'll see at the end that how sympathetic, parasympathetic can control. But as such, it doesn't require any motivation, and that's why it is called as this type of tissues. They are called having the function of automaticity. The crucial thing to remember, which is one of the questions, I'll write it over here in exam, if it is asked that what is the resting potential of pacemaker, remember there is no resting potential. There is no resting potential in pacemaker cells. So never it will happen like a flat line is coming. No, because if this flat line comes, that means the signals are not going from SA node. Then what heart will do, right? So here it is coming up the first part. Then what is called as the funny channel or the funny current. So here, as this is our cell. In this cell, slowly, gradually, sodium is entering. Right? Sodium is entering. So here, as the sodium enters, it means this cell. We always consider the cell as if we are sitting inside the cell and we are watching how much positive are we. Sodium is coming inside, right? This whole room is our cell. So sodium is coming from this door, from this window, from that window. Sodium is coming. That sodium comes, so it is rising. Potential is rising. This thing, right? This is called as phase 4. Why phase 4? Right? We'll just see. But This is phase 4. So what exactly is phase 4? This phase 4, it is called as the pacemaker potential. It is called as the pacemaker potential. So what is pacemaker potential? Pacemaker potential is that potential in which there is increased permeability for sodium, right? For sodium. So it is the sodium which is coming out from it, right? So that's why being the first step, the pacemaker potential, right? That step is called as the pacemaker potential, and that is phase 4. Is considered as phase 4. So we'll be having phase 0, phase 3, phase 4. So 0, 1, 2, 3, 4. Yes, we'll be having phase 0, we'll be having phase 3, we'll be having phase 4. What about this? No, there are no phase 1 and phase 2. Why? How is it possible? Mathematically, the 0, 1, 2, 3, 4. This is like when we'll be understanding it from non-pacemaker. We'll find that this 1 and 2, they are needed when someone else is motivating. That is needed. Otherwise, 4, straight away they are working. Right? So first point which you will be remembering is there is increased permeability. Permeability means ability to enter into the cell. Right? Increased permeability of incoming for no reason, just खुश हुए जा रहा है, right? This is becoming happy, and that's because of incoming sodium. And in the bracket will write slow. They are pretty slow. Now at this stage, though we have not discussed it in past, but today because we are going into the depth, I'll just say something about. We have already talked about that calcium channels, correct? Calcium channels. Now these calcium channels, they are of two types. Two types of calcium channel. One, what is called as the T-type calcium channel. T-type. And second, what is called as the L-type calcium channel. Not going into its histology and everything, but just remember L-type, that means it will be acting long. So this will be acting long. It will keep on acting for longer duration, right? While when it comes to T-type, obviously it will be for shorter duration. For shorter duration. So it is not only that much that we are dealing with calcium channels or calcium channels. Non-pacemakers are needed. Non-pacemakers are needed, right? In fact, just hang on. Once we complete this pacemaker, we'll be coming to non-pacemaker, right? So you will get the answer. So here it is. The calcium channels, there are two types, T-type and the L-type. Right? Okay. Chalo. Coming back to this. So we were talking about this funny current. So here it is. I'll keep on writing it like this. So this is that phase 4. So all the characteristics of phase 4 are here. It is called as the pacemaker potential. Right? So at one point, you think what is called as the threshold. Threshold is nothing. But when we were learning receptors, we were understanding that some of the receptors, they are the voltage sensitive receptors. So at minus 40 millivolt, some of the receptors, they'll go crazy. They'll go crazy, and there would be spike. If it is spike, that means things are going towards positive. So one thing is bilkul clear, some positive ion is entering into our cell. Okay. Now the game is in Viva, why to confuse? Sodium ने तो अपना काम कर लिया. The only which is powerful, which is mentioned, and that is calcium. Calcium enters. Is this calcium slow? No way. This calcium is fast, right? Pretty fast. So this is the entry of calcium channel. But we have got two types. One what is called as the T type and second one what is called as the L type. The T type and the L type. Now comes the mystery of it. From here till this point, that is when the spike occurs. Right. So this is calcium. So Iman, is there any question? Calcium channel. So here it is. So that this phase, right? This phase, it is for T type. T type calcium channels. Shorter duration. And then all the way when it reaches to that peak, right? This is L type calcium channel. So you got it? T-type calcium channels will be occurring in association with the slow sodium inward channels, input channels, and they will be only up to this trigger point. After that, L-type of calcium channels are already there, but now more number of L-type calcium channels they will be deployed, and it will lead to this rapid depolarization, right? When it goes up. At this point of time, when it reaches at the peak, so this phase is called as the phase 0. This is phase 0. So phase 0. This is the phase which is called as the action potential depolarization. Right? Action potential depolarization. So this starts when there is beginning of threshold, and over here during this time, what decreases? Sodium channel decreases, right? T-type calcium channel decreases. What would increase? Well, there would be increased L-type calcium channels. All these are USMLE questions. All of them, whatever you understood in this point of time, right? They just seize out some questions from it. But this is one of the favorite, L-type and T-type. So I hope so far clear, right? Because next part is so very easy. Any doubt, just let me know. So here comes the second phase. At the peak, now it is called as the action potential repolarization. So from here, things would drop all the way till this point, right? Single shot, right? It will go. So here it is here when the potassium will start going out. When potassium will go out, so this particular phase is called as the phase 3. Phase 3, which is also called as the AP, that is the action potential, right? Repolarization. Action potential repolarization. So what happens during this stage? There is one, or we write over here. So that was phase 4, phase 0, and then phase 3. This is phase 3. This is called as the action potential repolarization. Right? So here, sodium going out. This is called as hyperpolarization. This is called as the hyperpolarization. And then what was happening? Right? Those inward L-type calcium channels were there. They are closed. They are closed. Deactivated. Right? They are deactivated. So now you know it very well that when it comes to this point, it is the potassium, right, which starts moving out. Potassium is moving out. So when potassium is moving out, there was so much of plus inside. Plus ion is moving out, so it starts becoming negative, so it drops, right? And at the same time, these L-type, which were working almost till this point. Then some of the cells, they are working here also, here also. But inward, inward sodium channel, right? And these are inward calcium channels, and these are L-type. They are blocked. They are deactivated. And once again, the cycle keeps on repeating. That those sodium channels, once again, they start going down. And in order to function this whole thing properly, sodium potassium pump is always there, right? Do remember, sodium potassium pump, it is always there. It resets everything, and then once again the journey starts. Right? So again, from here, the funny current would start, and the cycle continues. So this is what really happens in case of pacemaker. Now we'll be talking about non-pacemakers. Non-pacemaker. So in non-pacemaker, heart minus AV or SA. The entire heart tissue except AV node, SA node and AV node. It has to be SA first. SA node and AV node. The rest is all considered as non-pacemaker. So non-pacemakers, that means there is no automaticity. They can't generate automaticity. They can't generate the impulse by themselves. So that's why you'll find that phases, phase 0, 1, 2, 3, 4, right? Phase 0 to 4 are present. Right? These are the two important ones. And third, is it having resting potential? 100%. Right? The phase 4. See, there was a phase 4. Phase 4 was this, right? So there was nothing like a baseline over here. No, it was never waiting. Right? So the wave would keep on going like this. So that phase 4, which is over here on slope, over here, that phase 4 is flat. And why it is flat? Because that phase 4 is the resting potential. Phase 4 is the resting potential. So let's draw it. So that becomes much easier. Right? So over, I'll draw it, take this. This is non-pacemaker action potential. That's 4. That's 4. Because that's the resting membrane potential. This is the resting membrane. So what really happens in case of when the signal comes? This is called as 0, phase 0. This one is called as phase 1. This one is called as phase 2. That's called as phase 3. And once again, obviously the phase 4 is there. So it continues. Let's decipher all the stages. So first, phase 4, this is the resting membrane potential. So this 0, which is going straight away up. So now onwards, we'll be writing action potential as AB, right? AP, action potential, right? So I'm just writing AP is equal to, I'm writing because I got few mails that short form pata nahi chal raha. So no worries, action potential. In fact, we have to use those short forms, right, as we proceed further. Abhi ke liye, no problem. So here it is, resting membrane potential, and this one would be the action potential depolarization. So something is going depolarization. The next one, this one, that is called as the early, because anything which is going up is depolarization, anything which is going down is called as the repolarization. Simple. But no, there is a change. This is called, this we said early repolarization. That means it has gone down, it has started going down, but then this comes into picture. A flattish line. This is what is called as the plateau. Plateau. So a plateau is formed. And then, because this was early, so there has to be someone late. So this is called as late. Right? The late repolarization. So these are the phases. Once again, the resting membrane potential comes. Correct? In this figure only, resting membrane potential. So there is what happened. What is the scenario over here? Resting membrane potential. We just go reverse. In resting membrane potential, this potassium, right? There was increased permeability, right? It was going out. Right? That potassium which was going out even over here, but we'll come to that. So, but it is still going out. But then what happens is, as the signal comes, impulse comes, this is fast sodium channels and L-type calcium channels. So over here, this resting membrane potential, it is what, I'll say it this way, because this is also one of the question about the sodium channels. Okay, let's take another page. For sodium channels, from sodium channels, there are two types of channels. The way over there, here there are slow sodium channels and the fast sodium channels. Right? Sodium channels fast and sodium channels slow. So resting membrane potential, nothing. This is the resting membrane, right? Our base level. When the impulse comes, first thing first, it leads to this action potential depolarization. So it begins with depolarization because of, say, depolarization of neighbor cell. Now, if you have attended right from the beginning, you will not be wondering that what is this neighbor cell, because it never happens with our muscles. Right? Our muscles, it doesn't happen that if this muscle has twitched, the rest of the muscle, the whole hand keeps on twitching. No, it is an abnormality. Right? But over here, in case of cardiac cells, if we really go into the depth of the histology, right, there are some discs. They are called as the gap junction. So due to this, the whole heart contracts like a single shot, right? It contracts together. So because of this gap junction is present only in cardiac cells. It is not present in any other tissue of the body. So over here comes. So this is the AP depolarization. So neighbor has sent some cell, some ions. Right? Neighbor has sent. So that is the action potential depolarization because of The neighbor cell has depolarized. Depolarized means it has acquired some ions. And which are these ions? What is happening? And this is where the fast sodium channel comes into picture. So when we say action potential, depolarization phase 0, so there is increased permeability of fast sodium channels. Right? They will come rapidly. As we'll see that why this was happening, it was happening because the large amount of that potassium, it was going out. So over here, this potassium, right, I'm writing out. This is stopped. Now potassium is not going out. Potassium is not going out, and large amount of sodium is entering. So that's why see this curve, this line, it will straight away go up. Straight away go up. So who is responsible? Fast sodium channel. You remember this? Fast sodium channel, they are responsible. Now at this peak, at this point, it stops, right? So there is for some time at the peak, right? So this just 2-3 events occur. So that's why I'm writing it here. So at first, this fast channel, right, it was going very rapidly, right? So that's why the sodium was entering. At this point, there is this outward fast sodium channels stopped. So that's why that peak which was going, now it has come to halt. And one more thing is the potassium, right? Potassium, it is said, okay, you start going out. Right? So we got that peak. So at that peak, sodium has stopped and potassium is going out. So now we get this fall. So over here, sodium out, sodium in has stopped and the potassium out has started, right? Potassium out has started. So this is what happens. Potassium starts going out. So that's why there is a fall. But that's why this is also called as this phase, right? This phase, which is phase 1, right? And it is also called as the early depolarization, early repolarization, right? Early repolarization. Because repolarization, it should come all the way down. So this is that. Right? We are now on to this stage. This is phase 2, which is called as the plateau. So over here, the cell is sending the potassium out. But it is at this point, calcium enters. Right? Those calcium enters. Which calcium channel? We understood that L-type and T-type, two are there. L-type. Because it has to be executed for a long time. So this is L-type calcium channels. So this L-type and potassium channels, they both balance each other. Right? So over here at plateau, outward move of this potassium is equal to inward move of L-type calcium. So the resultant this electrical activity is 0. Right? So that's why it is more or less like a flat line, and that is what is called as the plateau. And from here, at this junction, you must have guessed, right? This L-type calcium stops. The moment it stops, now it is the potassium alone. So potassium, now this has stopped. So now potassium will start pumping out. So immediately the whole thing will start dropping and will come down. So here, potassium channels they send, they open. Now over here in this late repolarization, we'll study that thing during arrhythmias. There are several types of potassium channels. Right? So it is in late repolarization, all of them open. So it is like a free flow. Right? So they open, that is one. And then there is deactivation of L-type calcium channels. Clear? So this is what really happens in case of non-pacemaker action potential. Now we need to talk about this variables. I'll keep this part. So we know that there are two types of system. One, what is called as the sympathetic system. Right? Sympathetic means stress. Sympathetic is for stress. So whenever there is stress, right, adrenaline secretion, right? And when, so there is beta 1 stimulation. Beta 1 stimulation. How to remember beta 1? Because heart is 1. Right? So that's how we remember, right? During our receptor lecture, right? We said that there was beta 1, beta 2, beta 3, right? So beta 1, it affects heart, beta 2 affects lungs, right? So lungs are 2, heart is 1. So this is now, that's why we are now talking about the beta 1 stimulation. That beta 1 stimulation, that will lead to increase in cyclic AMP, right? We saw that entire process, right? How the cyclic AMP, how those receptors, right, they come into picture, correct? So G protein coupled receptor, right? GPCR, right? G protein coupled receptors. So how it has got those, right? So it leads to stimulation of one after the another, the entire sequence. So that is that. There is finally cyclic AMP is released. That cyclic AMP, it does just one function. Right? Because we keep on wondering that beta stimulation, beta 1, those receptors, when they are stimulated, how the heart rate keeps on increasing. What really happens? It happens like that when the cyclic AMP is increased, it will lead to stimulation or the increased permeability. Permeability means how much it can really enter into the cell. So there is increased permeability of inward calcium channels. So now it makes sense. You know? Because if here, so these calcium channels, right? These calcium channels over here, right? When they open, fatafat. So this means that there won't be so much of waiting. That calcium channel has triggered to this point. It has, so instead of contracting from here, it is now contracting from here. Early contraction. When anything is happening early, that means its speed has increased. That means it will be able to contract for more times. So that's the reason whenever there is increased sympathetic stimulation, beta 1 stimulation, which leads to activation of G protein coupled of inward calcium channel, and calcium which is used, because if you go in more detail, right? So this calcium is as such less, but that calcium will be triggering sarcoplasmic reticulum. Sarcoplasmic reticulum, which is a heart rate, right? So that's how it occurs. Now, let me take you on a journey when we use a drug. Say, for example, hydrolysine or epinephrine. Right? So what is that? बहुत simple. Hydrolysine is, let's see this way. Hydrolysine is a vasodilator. Right? So it dilates the vessel. It is used for blood pressure. Right? It is used for blood pressure. So it is a vasodilator. So when there were small patle road, now there are highways. So the traffic will be able to go very comfortably, aram se. Correct? When this thing happens, what would really happen? There would be decrease in the mean arterial pressure. Medically, we'll think like this. Correct? Blood pressure, when we say blood pressure, systole and diastole, right? But it is decreasing mean arterial pressure. That means it is affecting both, right? Because now the highways are open, so blood is flowing easily. So far, it's okay. But how it will affect the heart? Itna to, right? It is good. Patient's blood pressure has gone down. If you keep on rubbing over here, right? There are carotid baroreceptors into our carotid. Right? They are called as the baroreceptor. Baro means pressure, right? Barometer. So they are the baroreceptors. These baroreceptors, they are connected with the heart, right? In fact, connected with the brain. So these baroreceptors, they are pressure receptors. When the pressure is more, these baroreceptors would be stretched, right? So they'll say, "Kare baapre, pressure is very high, pressure is very high." Right? They'll go and they'll tell the brain. Now what will happen? The blood pressure has decreased. So these baroreceptors, they are not stretched. When they are not stretched, correct? It makes sense. When the blood pressure decreases, these baroreceptors are not stretched. So these baroreceptors will not say anything to brain. A brain will think baroreceptors are not sending anything. Right? They are not stretching. That means they are not getting stretched, means pressure is less. It will call the heart to beta start contracting fast, right? So that will lead to increased heart rate. It will lead to increased heart rate. Now increased heart rate will do what? The blood will start pumping faster. When blood is pumping faster, now the blood pressure will rise. So then what's the role of this medicine? This is the reason you need to know the dose properly. Because at what point, how much medicine to give so that everything comes at a very proper equilibrium. This is the reason, right? So this is like in our entire body, there is a feedback mechanism. So sometimes there is negative feedback, sometimes there is positive feedback. Negative feedback is not bad. Negative feedback is there. That's why we are surviving. Right? Negative means when one thing rises, so then something drops. So that and this drops, once again, it keeps everything into control. Right? Otherwise, positive feedback is one rises, so it leads to rise of second. Second rise leads to rise of first. Right? So in that case, body won't survive. But there are certain areas where both are needed. So coming back to this. So this is what I wanted to emphasize is that why the dose is so important. Sometimes patients say, "Arey bhul gaya sahab." Right? You feel like kicking him. But yes, this is the point where if not they, we need to understand. And when we'll be going into the details of now, see how logical it is. When we'll be going into the details of half-life. Half-life means what? Half-life is when the effect of that particular drug is half, is 50%. So for example, apna coffee, right? Last time we were talking about coffee, right? So half-life of coffee is 6 hours. It means if I consume the coffee at 2 o'clock, 2 p.m. afternoon, so up to 8 p.m. Right? The effect of coffee over here, it was 100%, but by over here, it is 50%. Half-life, right? So its effect becomes half, right? So this is T half. So this means it will need another 6 hours when its effect will be 25%. Right? This is what really happens. That means even at night, 2 a.m., still there is coffee running into my body. So that is what is called as the half-life. That's why when we'll be talking about pharmacology, we'll be understanding many of the drugs, right? But every time we'll keep on telling what is the half-life, so that you need to adjust the dose accordingly. Why is it so? It will be metabolized into the liver. Some of the drugs, they are affected by even other drugs also, right? Say for example, if someone is on OCP, oral contraceptive pills, and you give antibiotic, right? Now it is like a young married female and she is on OCP, and suddenly she comes and she tells that I'm pregnant. Now you have prescribed OCP. What really happened was she suffered from a sore throat, right? Severe infection, and she was given antibiotics. Right? We'll see it in more detail, but when the antibiotics are given, that OCP, it neutralized the OCP, oral contraceptive pills. So its effect went away, it washed away. So in the next cycle, she got pregnant. Right? So this is what the importance of drug interaction, why it is so vital. Then we'll also be understanding that some of the drugs, they can enter they can cross the placental blood-brain barrier. That means that particular drug, if it is given to any of the pregnant female, that drug will go even into the baby, right? And it can cause certain problems. Right? So this is the importance of it. Now, same way, if we go for parasympathetic stimulation, some question. My dad is tonsillitis. What's secular? What is it? Okay, I will talk. So, parasympathetic stimulation. Now, parasympathetic stimulation, that should slow down the things, right? Because it will be affecting the pacemakers. Right? So, in that, there were M1 and M2, right? They were the two. So, this was the M2 stimulation, right? M2 stimulation. So, these are the parasympathetic receptors. So its function would be decreased cyclic AMP. So cool, right? When there is decreased cyclic AMP, what will do? Now you know that this cyclic AMP is affecting inward calcium channel, right? So in inward calcium channel, it was stimulating. Now the cyclic AMP itself is less, so obviously the calcium channels, they will also go like this, they will drop. When they will drop, it will lead to what? We'll say it will lead to decrease in heart rate, okay? But how? See this, one figure will explain everything. Previously, the situation was like this. This is how it was going. And this is the area in which we are interested, because this was the area where the calcium channels were working. Now, less calcium channels are involved. So the graph will become like this. It is taking more time and then it is good. See, taking more time. So taking more time means every process is getting slowed down, and that leads to decrease in heart rate. Right? This is one. The last topic, but very interesting. It is what is called as the sodium channelopathy. It is called as sodium channelopathy. It's a name ही बड़ा है, otherwise it's very simple. This sodium channelopathy, this classically occurs in non-pacemaker. In non-pacemaker, sodium is involved, right? It is telling that sodium is involved. They ask you the question that sodium channelopathy, it affects which phase, right? And then you are given the option 0, 1, 2, 3, 4. And nothing to worry. Sodium, it is telling sodium, right? You yourself will give the answer. Sodium. What it is doing, sodium channelopathy, right? It will stop, right? It will stop fast in sodium channels. Pathy means there is some problem, right? Cardiomyopathy. That means pathology has entered. Something has happened to the cardiac muscles. This is sodium channelopathy. Sodium channel, happy. Pathy means gaya, right? Something wrong has happened. So it will stop those fast inward sodium channels, right? Fast sodium inward channels. Which phase? Which phase? In which fast inward sodium channels were getting involved? Phase 0, 1, 2, 3, 4. Which one? Which one? Answer. Correct question. One answer. We are 40. Which phase? Phase 1. I will not take the name. कोई बात नहीं. Attempt. Right? This is which phase? Just two answers. यार बोला करो. This is phase 0. है ना? This is phase 0. This is the phase when there was fast. Let's take it over here. Here it is. है ना? This is the phase when there was fast sodium channels. They were open. That's why there was spike. Right? There was a spike, and then the rest of this channels they came into picture. Got it? So this is phase 0. Phase 0. Rapid depolarization. Right? This is rapid depolarization or the action potential depolarization. This is where it affects. So when see the questions are not difficult, right? So here when it is asked which phase, and so it is the rapid depolarization. Correct? Depolarization. So this is phase 0. That is affected. Simple. And now if I say, right, just to impress, that in exam you'll be asked the question that what happens in the Brugada syndrome. Kuch nahi. This is nothing but Brugada syndrome, right? So AKA also known as Brugada syndrome. So in Brugada syndrome, fast sodium channels are affected. When fast sodium channels are affected, so obviously that spike is affected. This one, the spike is affected. When this spike is affected, you are asked question that which phase, and you are given the option phase 0, phase 1, phase 2, phase 3, phase 4. Yeah, why to take trouble, right? It is over here only because it is then phase 1. So it is those potassium channels, they come into picture, right? And when over here for this, then calciums, they also come. So calcium and potassium, they balance. Calcium, they close over here. Potassium, they continue and they fall. And then once again, the whole cycle repeats. So not at all. Do revise this thing, those properly. I don't know why. मतलब इतने 40 लोग हैं and there were only 2 replies. Didn't like it. Say if there is any trouble, if you are not understanding, कोई भी problem हो, do ask. But if I ask any question, then do participate. And see, the person who has answered, right? The person who has answered, though it is not right, but she will always remember, yes, it is phase 0. मतलब you will hit on your head कि यार मैंने 1 कैसे बोला, है ना? You'll feel like. So whether it is like watching a detective movie, criminal movie. So if you detect that who is the murderer, then you feel like yaar I'm born smart. And in case if it is wrong, तो भी कोई बात नहीं, you'll always remember it. कि साला यार मैं इतना बेवकूफ, इतना समझ नहीं आया, but you'll always remember because emotions are involved. So that's why take part. Right? Any book for reference of the respected. Many books, all the books are there, but my favorite book, that is the Guyton. Guyton. What you are learning, it is not only from Guyton, it is combination of from many of the books. But Guyton, if you read this, right, yes, you will be getting all these things. It is wonderful. All right. So this is what is called as the Brugada syndrome. So if I say that in Brugada syndrome, in which there is sodium channels are affected. So that's why I'm just writing. Don't take any stress, because when we'll be learning arrhythmias, you'll automatically start learning it, right? But it is something which gives what is called as the pseudo bundle branch block, and that also right bundle branch block. So why should it really occur? We'll see that thing when we'll be learning the various bundle branch blocks, right? But the point is, that's how things are connected with each other, right? So that's it for today. Now the questions which you are getting, right? What all ebooks we need to refer from the medical library website? Okay. For the anatomy, no one of you will buy Gray's Anatomy, right? Don't buy. It is reference. So Gray's Anatomy, this is wonderful book, very nice figures, explanations, everything is there. But use it as a reference. Use it as a reference. So this one will be all of these are ebooks. All these are ebooks. So this is anatomy, right? For this, and for the physiology, say Guyton is superb. Right? Guyton is superb. So I'm telling you because from the ebooks, so that you can mark, etc. Those ebooks. Otherwise, normal books, they are always there. Other ebooks which will be of great use will be all the atlas. All the atlas. That histology atlas. Which edition? Always go for the latest edition, whatsoever is available, right? Is given to you. EV node वाला topic में right coronary as well as PDA both supply to EV node. See, it is depending upon the dominance. This one, right? This is a synode and this one is in node. Right? So this is supplied by PDA, right? But PDA is a branch of right coronary artery, correct? So that's the thing, that when it is supplied by right coronary artery, we call it right dominance. When this posterior descending artery is emerging from left anterior descending, from this, then it is called as the left dominance. Correct? So in most of the cases, it would be like a right dominance, 85% of the cases. For anatomy, the books which you use, which you should know thoroughly, that is the BD Chaurasia. So that you can appear for the exam effectively. Gray's to be used for reference. Then rest of the books like Sambulingam, they are available. That is also a very good book for physiology, right? Sambulingam. It's a good book. Then for embryology, I prefer Inderbeer Singh, but there are once again very good books. Inderbeer Singh. In Inderbeer Singh, you will find there are so many figures which will explain and which will make your concept very good. So this is for embryo. But for the reference, all those big books, right, they should be used for the reference, and e-books. So don't buy them. Don't increase the luggage unnecessarily. Whether you study from e-book or you study from the physical book, it's one and the same thing. And later on, you should really develop the habit of learning from e-books, because there will be so many books available. So many books. For biochemistry, Raghu Satyanarayan. For biochem, it is Satyanarayan. All right. So that's it for today. I'll just put it into our shared folder. So we are meeting on Saturday, right? This Saturday, right? Then we'll be meeting next Tuesday. We'll be meeting next Thursday. But on 24th, right? It's Sunday. Right? So I'm telling you in advance, it's Sunday. On 23rd, that is the Saturday. But that Saturday, there is pre-race fair, right? It's a big fair. And it starts at 2 o'clock in the afternoon. And so I'll be there for this. So we won't be able to meet on 23rd of November, right? Because next day the race is at 4:30 a.m. So in this fair, they give you all the details of the road and path and be your t-shirts, etc. About the USMLA books, well, initially the USMLA books, they will remain the same. Right? There is no change. There is no change. Specific USMLA books, so it is called as the first aid. It is called as first aid. Every year it is released. So first aid, right now, say it is 2024. So that is the book which is specifically for USMLE step 1. But in this, things will be given in very short and only the key points will be given. No descriptions. So actually, one should not really attempt this particular book. I just wrote it for your answer. Right? But actually, you should not read it. For first 6 months, focus only on these standard books. Only on these standard books. Make your concept very strong. Because in USMLE, you won't be able to cram the questions. Right? It won't be possible. You won't be able to cram it. You have to really take a judgment. So when I say something, so this is like, Sharon, this is how we do. Whenever I draw in any of the notes, when I do like this, so this means this was one of the USMLE question asked in past. Right? So this is like a symbol. So it becomes easy for me, easy for you also to understand that this was. So over here, Brugada syndrome, right? This was like one of the question, right? This Brugada syndrome. That was the question in past. So and this was the question that which phase. All right. So take care and see you soon. Thanks a lot. Take care.